Good morning and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Dr. Chini Puluru and I'm one of the co-chairs of PTAC along with Dr. Lee Mills. Since 2020, PTAC has been exploring themes that have emerged from stakeholder-submitted proposals over the years. Previous PTAC-themed based discussions have focused on topics such as reducing barriers to participation in alternative payment models and supporting primary and specialty care transformation, addressing the needs of patients with complex chronic conditions or serious illnesses, encouraging rural participation, and improving management of care transitions. At this public meeting, we have brought together various subject matter experts to gain perspectives on using data and health information technology to transparently empower consumers and support providers. We know that this topic is also of interest to the CMS Innovation Center. Before our first session of the day, we are honored to have opening remarks from Mr. Abe Sutton, the Director of the CMS Innovation Center and Deputy Administrator for the Centers for Medicare and Medicaid Services. Mr. Sutton previously served as the principal at Rubicon Founders, where he co-founded two health service companies, Honest Health, which focuses on enabling primary care physicians, and Evergreen Nephrology, which focuses on enabling nephrologists. From 2017 to 2019, he also served at the National Economic Council, Domestic Policy Council, and the Department of Health and Human Services. In these roles, Mr. Sutton coordinated health policy across the federal government with a focus on value-based care, increasing choice and competition in healthcare markets, and updating the federal government's approach to kidney care. Welcome, Abe.
Thank you for having me today, and good morning to all the members of the Physician-Focused Payment Model Technical Advisory Committee. In March, I had the opportunity to join you all for a public meeting where I delivered some of my first remarks in any setting in this role. In that conversation, I got to preview at a high level some of our strategy before we came out with it. Since that time, we came out with a public-facing strategy describing how we were approaching our portfolio at the Innovation Center and what new models would focus on. I'd like to take the opportunity today to speak in a bit more depth about that strategy now that it is public. One of the exciting things for me leading the Innovation Center has been to see the PTAC show interest in our strategy and to see the alignment between the themes the PTAC is focused on and where we are focused as a center. Our strategy focused on evidence-based prevention, empowering people to achieve their health goals, and choice and competition in healthcare markets gets at the core of the changes necessary to transform the healthcare system into ones where people are empowered to live healthier lives and to truly make America healthy again. So to get started on that, our first strategic pillar is focused on evidence-based prevention, where we're really working model by model to embed prevention within each model, taking a deliberate view on primary prevention or disease prevention to tertiary prevention, the focus on managing chronic diseases. We are also focused on driving choice and competition in our third pillar, namely through reducing administrative burden for independent physicians engaging with our models, simplifying and standardizing our portfolio choices to make them easier to navigate, and creating more predictability in our models through standardizing quality metrics. It doesn't make sense to report things 6 different times to CMS, so they show up in different payment structures. If we could access the data once and then do the customization required to put it in forms, or even use the same exact measure is we want the same incentive facing people in clinical practice, that would make things easier to navigate. But today's conversation will mostly focus on our second pillar, patient empowerment. When we think about patient empowerment at the Innovation Center, we really mean that we want patients to be in the driver's seat for their healthcare outcomes, which means they have the resources, information, and incentives to achieve their health goals. That means we're working through our future model tests to equip patients with the information they need at their fingertips to make informed decisions, to make the right choice, and have it presented in a clear format where they're positioned to understand their health status, to set goals, and to make decisions with their providers, engage more actively in their care. In terms of what patient empowerment means for our models, in a more concrete sense, it could be different approaches to data sharing, or new CMS apps and reimbursement structures for them, or testing wearable devices in the context of our Rapid Cycle Innovation Program. It could mean finding new payment flexibilities to activate patient engagement in their health and promote healthy living. Very often in the center's model design experience, we think about the driver of behavior and the driver diagram that is involved. And we think about this often from the provider experience. We're very focused on how providers engage with our models, the experience they have, what incentives they have to act in different ways. Taking that same perspective and now applying it to patients is the core of this pillar. Well, what is the patient experience? What are the choices they are presented with at different junctures? And how can we engage with them to empower them? Looking at their choices and what they face, there are a couple of things that we can do to shape them. We could shape the provider's incentive to engage with them. We could open up markets for people to go and engage with patients. And we could also think, based off that, about partnerships with industry and community advocates to promote awareness and uptake on different opportunities, flexibilities, technologies, as they're made available to patients in Medicare and in Medicaid. In the months to come, we expect to be able to share more about work coming out of this pillar. And so I'm very excited for today's conversation, which will help bring it to life for us, bring examples to the fore, and spark innovative ideas. As I said in our last conversation in March, I want to emphasize that this new strategic work focused on empowerment, prevention, and choice and competition is aligned to the Secretary's vision to make America healthy again. To close, I want to thank the members of the PTAC for their commitment to creating this forum for robust discussion where we hear from those in the field directly about their ideas and concerns for how to deliver high-value care for Medicare and Medicaid beneficiaries. This independent expert committee is a critical resource as we develop the way forward to achieve Secretary Kennedy and Administrator Oz's vision and accomplish our goals as a center. So thank you, and I look forward to today's conversation.
Thank you for sharing those remarks, Abe. We appreciate your continued support and engagement, and we look forward to continuing collaboration with the CMS Innovation Center. For today's agenda, we will explore a range of topics using data and health information technology to transparently empower consumers and support providers that include, first, approaches for improving data infrastructure and interoperability to support patient empowerment and provider decision-making. Then, effective digital tools for equipping patients with information about their healthcare. Third, emerging strategies for promoting shared decision-making between providers and patients. Fourth, data-driven approaches for enabling patients with multiple chronic conditions to take control of their healthcare. And last, payment models and benefit design improvements to enhance patient empowerment. The background materials for this public meeting include an environmental scan will be posted online on the ASPE PTAC website's meeting page. Throughout the meeting, you will hear from many esteemed experts with a variety of perspectives, including a previous PTAC proposal submitter. I also want to mention that tomorrow afternoon will include a public comment period. Public comments will be limited to 3 minutes each. If you would like to give an oral public comment tomorrow but have not registered to do so, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. The discussion meetings and public comments from this public meeting will inform a report to the Secretary of HHS on using data and health information technology to transparently empower consumers and support providers. Over the next 2 days, the committee will discuss and shape our comments for the upcoming report. In July, we posted a request for input on ASPE PTAC website to give stakeholders an opportunity to provide written comments to the committee on using data and health information technology to transparently empower consumers and support providers. To date, we have received 5 responses that the committee may consider during their discussion today. Lastly, I'll note that as always, the committee is ready to receive proposals and possible innovation approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about submitting a proposal on the ASPE PTAC website. At this time, I would like my fellow PTAC members to please introduce themselves. Please share your name and organization. If you would like, feel free to describe any experience you have with our topic. First, we'll go around the table, and then I'll ask members joining remotely to introduce themselves. I'll start with myself. Hi, I'm Chini Puluru. I'm a family physician by trade, having practiced for about 15 years. I led a large medical group in clinical operations, Duly Health and Care, the largest multi-specialty independent group in the country. After that, I found my way to Walmart, where I led the expansion of Walmart Health and their clinical operations nationally, including integrating their telehealth platform. Currently, I serve as a co-founder of 2 organizations, the founding CMO of an agentic healthcare AI company that enables patients in choice, and a genetics company as well. I work also as fractional chief medical officer, Stellar Health, which is a value-based care transformation platform. Lee?
Thank you, Jenny. I'm Lee Mills. I'm a family physician. I am Chief Medical Officer at Aetna Better Health of Oklahoma, one of the state's 3 contracted managed care Medicaid organizations. I've spent my career starting out in rural primary care in central Kansas, and then worked up through multi-specialty health systems and multi-specialty medical groups, leading practice transformation, clinical informatics, and into value-based care. I've had the pleasure of practicing in and/or leading operations through 5 or 6 different CMMI models over the years.
Hi, I'm Jay Feldstein. I was a practicing emergency medicine physician for 10 years and then spent 13 years in the health insurance industry in the commercial and government space, running Medicaid plans in 5 states. And for the last 11 years, I've been the president and currently of Philadelphia College of Osteopathic Medicine. Thank you.
Hi, everybody. I'm Krishna Ramachandran, Chief Information Officer for Operations and Experience for United Healthcare. I've been in healthcare for 23 years in payer, provider, and tech perspectives. And so the topic we're covering today on using technology and data to empower consumers and support providers is work I've done. It's been my life's work, and excited to dig deeper into this topic today.
Good morning. I'm Lindsay Botsford. I'm a practicing family physician in Houston, Texas, where I continue to care for patients and serve as a medical director for the Midwest and Texas with One Medical. I started in large health systems and multi-specialty groups and graduate medical education as residency faculty before transitioning in 2019 to join Iora Health as we expanded to Texas. We are now part of One Medical, where I support our practices across the greater Midwest and Texas.
Good morning. I'm Walter Lin, the founder of Generation Clinical Partners. We're an independent practice that serves frail Medicare beneficiaries in senior living settings, nursing homes, and assisted living. We are also involved with a variety of value-based programs, including MSSP, PACE programs, as well as institutional special needs plans.
Now we'll go to PTAC members joining us on Zoom. Lauren, please go ahead.
Good morning. I'm Lauren Harden. I'm Chief Integration Officer for HC2 Strategies. I'm a nurse by training and have spent the better part of the last 30 years in model innovation and development, originally in hospice, children's hospice and palliative care, which is deeply focused on informed decision-making and partnering with patients. And then moved to Camden Coalition to help start the National Center for Complex Health and Social Needs, innovating models and development for those with the most complex needs, and also deeply partnering with clients, including establishing programs like consumer scholars to really inform policy and implementation. And now currently with HC2, work across the country on model implementation and partnerships with patients in the dual eligible and Medicaid space very deeply.
Larry?
I'm Dr. Larry Kaczynski. I'm a retired gastroenterologist. I practiced for 35 years in private practice of GI in suburban Chicago and was one of the founding partners of the largest GI group in Illinois, the Illinois Gastroenterology Group, which is now part of the largest GI practice in the country, the GI Alliance. 10 years ago, I entered the value-based care space and founded a company named Sonar MD, which brings value-based care solutions to the GI space. It started as a PTAC proposal. Currently today, I am the Chief Medical Officer of Jonah, which is an AI-powered microbiome solution. I also recently founded my latest company, Vocnomics, which is a company built around a wellness product that uses AI to enable people to monitor their soluble fiber intake in hopes of controlling their weight. I've been on the committee for 4 years. I'm sorry I'm not there in person, but I will participate remotely.
Josh?
Internal medicine physician by training and a professor and distinguished chair at the University of Texas Southwestern Medical Center. Over the last 10 to 15 years, I've spent time, whether through research, advisory, leading operational and strategic programs in population health, value-based care, and many kind of delivery and payment topics salient to this issue of physician-focused payment models. Increasingly over time, data and technology factor critically into this issue, and an increasing research pillar in our work, as well as advisory pillar, focuses on how do we kind of, within a regulatory and policy framework, deploy technologies and solutions, many of which I think we'll talk about today, to improve health outcomes, et cetera. Those things relate to remote patient monitoring, wearables, et cetera. Excited to be here on the topic for this meeting.
Thank you. Now let's move to our introductory presentation. PTAC members, you'll have an opportunity to share any comments or ask any follow-up questions after both presentations. First, 4 PTAC members served on the Preliminary Comments Development Team, or PCDT, which has collaborated closely with staff to prepare for this meeting. Krishna Ramachandran was the PCDT lead, with participation from Larry Kaczynski, Josh Lowe, and Jim Walton. I'm thankful for the time and effort they put into today's agenda. The PCDT will share some of the findings from their analysis to set the stage and the goals for this meeting. And now I'll turn it over to Krishna.
Thank you, Ginny. As Ginny mentioned, I'll provide an overview of the work that the team had done there. The topics we'll cover are 5 key objectives, and Ginny shared some of them as well in the opening comments. One is on improving data infrastructure interoperability, largely to support patient empowerment and decision-making. 2 is on effective digital tools for equipping patients with information about their healthcare. 3, examining emerging strategies for promoting shared decision-making between providers and patients. 4, assess data-driven approaches for enabling patients with multiple chronic conditions to take control of their healthcare. And most importantly, given the charter of the committee, discuss payment models, provider incentives, and any benefit design improvements to enhance patient improvement. Additional context. So PTAC has received 35 proposals for physician-focused payment models. And as you would imagine, nearly all of these proposals addressed patient choice and health information technology. Specifically, 25 out of the 35 proposals met the criterion for patient choice, and 22 met the criterion for health information technology established by the Secretary. And we found that 4 proposals provide specific strategies to support patient choice, and 3 proposals describe approaches to health IT as well. And in the rest of my presentation, I'll cover these 4 topics, provide more background on the themes that we're going to be talking about today and tomorrow, including data infrastructure, patient-provider-facing digital tools, as well as the empowerment, particularly in the context of alternative payment models. And so what we've seen in our research is there are many terms that are used to describe patient-centered care. And so the definitions have varied and have some overlap, but the key terms are patient enablement, activation, empowerment, engagement, involvement, and participation. And conceptually, these cover a few areas. One is on patients' knowledge and skills, their confidence and motivation, and their actions and behaviors. And so you'll see that 2 central themes we will focus on this presentation are patient empowerment and patient engagement. And so from a working definition perspective for empowerment, we've come up with empowerment as the process and state whereby a patient acquires and has the ability, so knowledge and skills, and motivation, so desire and confidence to control and make timely decisions regarding their own health and healthcare. So takeaways are patient has ability and motivation. And so we'll keep using this in the context of this meeting, and I presume we'll evolve this thing as we get more feedback from our experts as well. And then the second concept is on patient engagement. So the definition we've come up with is the process and state by which a patient actively communicates their health status, healthcare needs, and healthcare wishes, makes informed decisions regarding their healthcare treatments, and participates in shared decision-making regarding their health with their providers. And so the takeaways are patients communicates actively, makes informed decisions, and participates in shared decision-making with their provider there. We've also come up with this conceptual framework, which I thought was helpful to tie all these topics we have together. And so this framework is from existing literature. On the left side of the framework are the inputs into the empowerment system. So think health data, health information, provider support, as well as organizational and societal context. And the middle section is really the empowerment system, which touches on knowledge and skills, patient empowerment, as well as engagement. And they're meant to be circular in the sense that they're sort of self-reinforcing behaviors as well. So having the knowledge and skills can make the patient feel empowered, and feeling empowered can motivate the patient to seek out more information as well. And the right blue box are the important outcomes that we want to achieve. And so these include things like patient satisfaction, improved financial health and clinical health as well. And so we'll use this framework in the course of my overview presentation, as well as touch on topics that the next 2 days. And so as I dig into the framework some more, 3 areas where a patient can be empowered to make informed decisions are 1, choice of health insurance and their providers, 2, use of the healthcare system, and 3, their own health conditions and treatments. Obviously, given the topic, the ability for patients to obtain and comprehend data is critical to their making informed decisions. And there's, of course, various factors, which I'll click on some more in the upcoming slides, that can influence the empowerment. From a factors perspective, we want to introduce 5 factors that can influence patient empowerment. Patient factors, which include things like education, literacy, beliefs, and experiences. Provider factors like structure, goals, training, incentives, and business models. 3, organizational factors like policies and procedures. 4, cultural factors, so think like norms and values and communication styles, language barriers, and conflicting information sources. And for the 5 societal factors, such as state, local, and national policies and programs. The next 3 slides walk through key areas where patients can be empowered to make informed decisions. First area is choosing a health plan and providers. And so there are many tools that are available to patients to make decisions about their choice of health plans. So Medicare Plan Finder is one example, as well as brokers that can give patients information on plan choices that meet their needs. As many of you know, in the commercial space, the system actually limits choice because most beneficiaries and most people get their coverage through employer-sponsored health plan, which we've seen only about 54% actually have more than 2 choices. The other choice is on providers, which CMS provides a variety of tools for selecting providers, including online comparison tool, consumer assessment tools, as well as other factors like provider proximity and experience with the provider themselves. The other aspect is on empowering patients to navigate the healthcare system, and patients can be provided different choice, particularly around virtual options like telehealth and online appointment scheduling as well to help them navigate the system. Patient empowerment, the third area I wanted to cover is empowering patients to make informed decisions about their own health conditions and treatments. We believe shared decision-making is a key concept, and it's important to engage a patient in their own healthcare journey. This involves 3 steps: patient awareness on the need for a decision and choices, patients discussing options in a 2-way conversations with their provider. So the emphasis is on aligning their medical conditions with patients' personal goals. And then patients are supported by their physician in making an informed decision. We also think supporting providers is key to empower patients. And this could be in engaging the patients in shared decision-making. This could be in encouraging and supporting providers to focus on patients' overall lifestyle choices. So think exercise, social activities, nutrition. Engaging in emerging concepts like social prescribing, in addition to prescribing drugs and therapies. And using asynchronous communication to engage the patient outside of regular visits. So using a patient portal, so that the patients can submit questions and doctors can review and go back and forth with their patients beyond their scheduled appointment times, as well as using emerging tools like artificial intelligence to review the large amount of collected information from remote monitoring, as well as using that to engage patients in communications as well. From an impact perspective, we think there's limited but promising evidence showing patient empowerment can be improved. Particularly, we're focusing on 3 types of outcomes: improving patient experience, so higher quality provider interactions, more frequent communications, improving patient-reported outcomes, so quality of life, self-efficacy, as well as clinical outcomes, so lower blood pressure, fewer emergency visits, and hospitalizations. My next topic is on data infrastructure, the challenges and opportunities. You'll see we'll follow a similar conceptual diagrams and lighting up certain areas that are relevant to this section. So health data information is lit up, as well as use of digital health tools and digital health literacy. From health IT types, there are 3 kinds that we think can promote patient empowerment. One is information that's part of the patient's electronic health record. 2, information that helps patient interpret their electronic health record, so think patient portals, or provides patients directly with information about their health, so wearables, mobile apps. that we think should be integrated with the EHR so that it's cohesive, comprehensive information there. And then 3, AI and emerging technologies that we think can further assist providers and patients, so chatbots and remote patient monitoring tools. Interoperability is essential to make sure we can really optimize the value of health IT. So we think being able to collect the patient that across various domains is important, and we think interoperability is a key foundation enabler. We think it's also powerful to be able to share that data and integrate that data into many systems as well. As many of you know, there have been many regulations and initiatives on interoperability over the last 15 years. We have some examples of them. Obviously, we had a recent pledge as well that CMS led with just improving interoperability through the healthcare tech ecosystem, and we want more such initiatives to continue the promotion of interoperability to further sort of data liquidity between the stakeholders there. There are a number of challenges related to interoperability that I wanted to highlight today. One is on lack of standardization, 2 on lack of integration of patient-reported data into the electronic health record, and 3, just like resources and cost demands. Of course, there are multiple efforts and opportunity as well underway to improve the data interoperability. So whether it's promotion of HL7 FHIR standards, using APIs to integrate patient-generated data, or furthering our incentive programs to promote healthcare IT adoption. Patient use and access of data also has some challenges and opportunity. One is on just general health literacy itself. 2 is on barriers to accessing technology. 3 is issues with having real-time access to data. And 4, patient privacy and confidentiality. We think, of course, as with all of these challenges, there are opportunities, of course, to improve patient-related use and access barriers. And some of those are tailoring patient education materials to specific needs of the patient, designing technologies in a simple and organized and clear manner, determining the balance of real-time data for patients, as well as ensuring clinical interpretability before the data gets pushed out, and more importantly, ensuring patient control over their health data. My next topic is on patient and provider-facing digital tools. Similar to our previous sections, here are the sections of the conceptual diagram that get lit up. We've produced a few classifications there. We've used a framework from the Digital Therapeutic Alliance and Health Advances to classify digital health tools across sort of the journey of their use in the patient care process. So first classification is just health and wellness tools. And so these constitute the bulk of digital health tools we're seeing. These tend to not be regulated. They're aimed at preventive healthcare. So think wearables and apps focused on diet, exercise, sleep, and other wellness factors. 2 other types of digital health tools are used to help diagnose a patient condition. So these could be health system clinical software. So think like clinical documentation, imaging, clinical decision support, or telehealth tools. Primarily clinician-facing and involves diagnosing a patient. And the second category is digital diagnostics tools, which are considered medical devices and highly regulated. My other section is on tools that are in the treatment and self-care categories. So these include care support tools that can promote patient self-management of their conditions. Includes tools like medication trackers, physical rehab apps, and educational tools, as well as therapeutics, which tend to be, again, highly regulated, provide medical therapeutic intervention to the patient. So think like sensory stimuli. Finally, we have 2 types of digital health tools targeting a phase during which patients and providers monitor the patient's conditions. One is on patient monitoring tools, so remote tools that can help both patients and physicians monitor the condition, as well as tools that are in the healthcare clinical systems as well. So documentation, imaging tools that document things like patient telehealth visits, which can be used by clinicians to facilitate ongoing monitoring of the patient's condition. We think digital health tools can really promote shared decision-making, specifically in the care support and patient monitoring categories that educate patients to encourage their engagement, as well as tools that allow patient disease management data to be reported back to the provider, promoting a two-way engagement between patient and provider. Care support tools can include apps that aid in disease management, decision aids that facilitate education, and monitoring tools as well, so that active dialogue can happen between patients and providers and encourage the patient in participating in their healthcare journey. From effectiveness, we're seeing limited but promising evidence that's showing that digital health tools can increase patient empowerment and improve clinical outcomes. For example, we're seeing some evidence around patient knowledge being improved as well as activation. And some studies have also shown that tools can affect clinical indicators such as hypertension, pain management, and depression as well. My last topic is on these tools and how it relates to the primary charter of PTAC on alternative payment models. Again, I'll follow a similar conceptual diagram highlighting the areas. These could be incentives to empower patients as well as incentives from the provider perspective as well. And so I want to share some examples where active empowerment to patients is being incorporated into payment models. And so I have some examples here, not intended to be exhaustive, on innovation center models where these patient empowerment is and engagement is incorporated. One is this transforming maternal health TMAH model, which launched at the start of the year, which encourages providers to actively listen to their patients to promote greater patient empowerment over the birth experience. And the recently announced ambulatory specialty model, scheduled to launch in 2027, targets specialists and includes components that promotes patient engagement and interaction, such as discussion of lifestyle-based interventions. We expect patient empowerment strategies in innovation center models to continue to increase. As you heard from Abe, it's a key pillar in the innovation center strategy as well. We've also seen patient empowerment in the Medicare Shared Savings Program. As you are aware, that's the largest program in Medicare related to alternative payment models. We have 480 ACOs covering 608,000 clinicians and nearly 11 million Medicare beneficiaries, so it's a pretty big program. The Shared Savings Program includes patient empowerments in the models by promoting patient-centered care, involving patients in the decision-making process. It also aims to improve communication between patients and providers, allowing for patients to choose their providers. The Shared Savings Program is a prime opportunity, we think, to promote and test patient empowerment strategies. From a total cost of care, these models, we feel, provide opportunities for patient empowerment in a few dimensions. One, for providers, we think it has financial incentives to encourage patient empowerment, including waivers that can allow providers to offer patient engagement incentives. And from a patient perspective, education elements to promote participation in total cost of care models, as well as benefit design improvements that we think can incentivize patient empowerment as well. With that, you'll see in the next 2 days, we will focus on the key topics that I shared. infrastructure, availability and effectiveness, data strategies for shared decision-making, data-driven approaches for enabling patients, particularly with chronic conditions, to enhance secondary prevention, as well as payment models and benefit designs. And so you will hear from our subject matter experts nationwide. I hope it's an enlightening discussion in the next 2 days. Thank you all for joining us. Ginny, I'll give it to you.
Thank you, Krishna. Next, we have Kaushik Ghosh, an economist with the Office of Health Policy at ASPE, who will share the results of an analysis of patient-reported health outcomes and experience measures. Kaushik, please go ahead.
Thank you. Good morning, everyone. This presentation draws on new evidence from OECD's Paris survey, which is focused on patient-centered outcome and experience measures. So Paris is an OECD initiative that focuses on people aged 45 and older with chronic conditions. The survey collected patient-reported outcomes and experiences across 21 countries with the goal of generating comparable data to improve primary care performance and highlight patients' perspectives on health outcome and care experiences. In the United States, participation came through a special segment of the Medicare Current Beneficiary Survey. It focused on beneficiaries 65 and older living in the community and surveyed in winter of 2023. The sample included 4,200 beneficiaries representing more than 50 million Medicare beneficiaries nationwide. The Paris survey asked a structured set of questions that fall in 3 broad domains. Together, these domains capture health outcome, how people manage their health, and their experiences with the healthcare system. The first domain is self-reported health with 15 questions. This covers areas like general, physical, and mental health, as well as social functioning and overall well-being. In this presentation, we will focus on 2 key domains of the survey related to patient empowerment and provider decision-making. First, managing health and healthcare. This focus on people's behaviors and engagement, things like confidence in managing health, health literacy, and shared decision-making with providers. The second is experience of healthcare. This focus on survey questions related to usual source of care, care coordination, support for self-management, and person-centered care. These slides provide an overview of the characteristics of the US beneficiaries included in the Paris survey. 74% of the beneficiaries are either enrolled in a Medicare Advantage or an alternative payment model like an MSSP or an Innovation Center model. Roughly 28% have a high school education or less. 22% live in rural areas. 70% of the beneficiaries are either overweight or obese, and 80% of the beneficiaries live with 2 or more chronic conditions. So overall, the US Paris sample broadly represents the elderly Medicare population residing in the community. So let's start by looking at some of the key findings on how Medicare beneficiaries are managing their health. When it comes to lifestyle, there are some areas of concern. Nearly 30% of Medicare beneficiaries report getting no weekly physical activity at all. Dietary habits also raise concerns. About 1 in 5 beneficiaries report eating fruits and vegetables only once per week. We also see potential issues on how often these activities are addressed in clinical settings. Around 60% of beneficiaries say they talk with the provider about physical activity, but only 40% report conversations about healthy eating. So this clearly indicates the potential for improvement in nutrition and exercise counseling. On the positive side, most beneficiaries express confidence in managing their health. About 3/4 say they are confident in identifying medication side effects, knowing when to seek medical help, and managing their overall well-being. However, the confidence in managing health is significantly lower for beneficiaries with Alzheimer's and dementia at 32%, kidney disease at 62%, and diabetes at 66%. Most beneficiaries report being engaged and proactive about their health. 93% feel they receive enough support from the providers, and nearly all, 97%, say they try to understand their personal health risk. About 3/4 of the beneficiaries actively engage providers with health information, and the majority feel they are working with the providers to manage health and raises concerns when needed. However, there is heavy reliance on providers to make right health decisions. Over half of beneficiaries, about 54%, rely on them to make the right decisions to manage health, and 53% depend on providers to supply all the information they needed to manage health. Again, health literacy continues to be a challenge. About 22% struggle to understand health information, and 17% say most health issues are too complex to follow. Reliance on health professionals is especially high among certain groups. About 70% of the beneficiaries with high school education or less, and those aged 85 and older, report depending heavily on providers to make decisions. Difficulty understanding health information is also concentrated among more vulnerable groups. About 41% of those with high school education and less, and 38% of females 85 years and older, they struggle with understanding health information, nearly double the average rate. Finally, perceptions of complexity mirror these disparities. About 34% of this with less than high school say health issues are too complex to follow, compared to 17% overall. Now, turning to care coordination and patient experience, 2/3 of beneficiaries, about 67%, report having some help coordinate their care across services, but that still leaves about 1 in 5 who do not have this support. In addition, about 20% report having to repeat information that should already be in their medical records, pointing to persistent challenges in record sharing and care coordination. Encouragingly, most beneficiaries feel included in care decisions. About 74% also feel they are treated as a whole person, not just as a patient defined by their condition. So this shows progress towards more patient-centered care. About 65% say they often or always get enough support from providers to manage their health. But formal care planning is less common. Only 28% report having a care plan that considers well-being. So this suggests that while providers offer general support, there is room for improvement in structured care planning. So overall, beneficiaries report high levels of engagement with providers. Most surveyed beneficiaries reported they participated in shared decision-making, were motivated to understand their health risk, and feel confident they're getting information to manage their health. There are potential areas of improvement. Many Medicare beneficiaries, especially oldest adults, those with lower education, and people with multiple chronic conditions struggle with understanding health information and rely heavily on providers for decisions and often lack a useful care plan. So the focus of the 2-day meeting will be technology, infrastructure, data, and incentives, and that will empower patients by enhancing patient-provider engagements, providing better information to patients for managing health, and improving health literacy. So important takeaways from the meeting will be the implications for designing alternative payment models that resource and incentivize these elements of patient empowerment. Thank you for joining.
Thank you, Kaushik. Before I open it up to the full committee, do any of the PCDT members have something to add?
I would be happy to start this piece. First of all, we were very fortunate to have Krishna with his expertise to lead the PCDT. It was a pleasure to work with him on this team. I just would like to emphasize the challenges. Integrating structured patient-reported outcome data into the EHR is a significant challenge. Integrating data from structured data from wearables is a significant challenge. We really can't promote proactive, high-touch care unless we can accomplish this. We also need to convert our EHRs from a one patient at a time structure to more of a population health structure. And then finally, we have to figure out how to incorporate all of this into alternative payment models that incentivize, that brings information to the patients and intelligence and appropriate incentives. I look forward to the discussion these next 2 days.
Thank you, Larry. We have about 10 minutes prior to break, but I would love to open it up to the committee for questions. So PTAC members, do you have any follow-up comments or questions for Krishna and the PCDT or for Kaushik? To indicate you have a question, please flip your name tent up on its side for our virtual committee as well. And on the screen, if you have questions, please raise your hand. I'll actually start with the question to Krishna as well as the PCDT members. And anybody on PTAC, please weigh in. You know, part of the struggle here is equity, in the sense that anytime we bring in data, infrastructure, or patient empowerment tools that are based on technology, you do run into the fact that large parts of this country don't have broadband access or don't have access to the technology that's needed in order to make these solutions work. So from your perspective, how do we bring forth these solutions and in parallel solve for some of these challenges?
Yeah, great question, Jenny. I think for me, yeah, this is the sort of the tensions of technology, right? Like, how do we continue to advance and move forward while still making sure that, you know, sort of disparities are sort of bridged in the process there. So I think my perspective, I think continuing to emphasize some of the incentives that are available so that we can increase adoption, I think would be key, whether it's base technology adoption, core infrastructure adoption, to ensure that both providers and patients have access to the technology will be important. Because otherwise we're going to be creating just expanding the divide that we already have in technology adoption in our country.
Lauren, I believe you have a question.
I was going to ask exactly the same thing, Jenny. So you covered it.
And Lauren, I'd love if you have perspectives on ideas you think we should do as well to bridge. I know this is work you've done as well, Lauren. I'd love your perspectives as well.
I think it's a really important question to consider because there is so much promise from all of these different ways of engagement. And that can be so helpful, especially in rural, when you think about telehealth or wearables and just the ability to access a high level of care without needing to have transportation and drive and really go long distances. But where the investment in that infrastructure comes from, I think is a key question in advancing patient choice and patient engagement in this sector. So I've seen different statewide initiatives, but I'm curious for both you and Kaushik, if anything came up in recommendations in the incentives or in who should invest in building that infrastructure.
Yeah, I think as with most of these incentives we've seen, has to be sort of cross stakeholder, cross functional there. I think particularly states that have invested in infrastructure, I think certainly have benefits, particularly on like one of the things that has come post-pandemic, at least for me, was the ability of virtual care to really expand access in rural parts. It's like quite remarkable to see the power of technology. But I do think the core infrastructure has to, the investments have to be made as well to even, get broadband access, to even get access to virtual care. Obviously, it's a cross-functional effort there. I would love to see just more leadership from the states as well on that.
I do think there's a regulatory component as well. So I work nationally and my company's in California, but I live in Kentucky in a rural area. And in our local town, the person that has control, the company that has control over internet access is a much lower delivery or much lower capacity than is actually available. But because of political control in the area, higher levels of bandwidth and higher levels of access, it's not an option to put it in place, even though it's actually technically available. So there's the investment, and then there's also the regulation of how that gets rolled out on a national level.
That makes sense. Thank you.
We have time for one more question. So if anybody wants to ask a question. I'll ask a question again. Sorry, I was trying to get someone else to ask this, but Kaushik, in your presentation, you spoke a lot about caregivers. And, what I'd love to hear from the team is how do you feel that, given what patients that were surveyed were saying about how important caregivers are, how those incentives need to be aligned in order to move the needle on using technology and using data services?
I think that there should be strategies that focus on specific age groups who are most vulnerable, like people with lower education and elderly, because it looks like the survey says that they are struggling with even getting information from the doctors. And so I think any policy that has to be tailored towards specific groups, and there cannot be just one thing, standard strategy for everyone. So it has to be a tailored strategy for their needs for specific population.
Krishna, do you have any thoughts on caregiver alignment using technology?
Yeah, I think I particularly for app developers out there, right? I think like factoring in the fact that the patient themselves may not be able to use it, that we'll need to have abilities for the record to be shared with caregivers, whether it's to translate information or to engage in communication. So I think just factoring that sort of stakeholder into the mix, I think, will be key. I do think this provides opportunities for caregivers to have just a better view of the health information. So I think in terms of making the data more liquid and available to people that are taking care of the member, I think it's just definitely some power there. So I'm excited for the opportunities that come with it, assuming the features are actually enabled. The key would be just identity management, of course, the consent process, and feature enablement from my perspective.
Great, thank you. Thank you, Krishna, and the rest of the PCDT team, as well as to Kaushik. Those were wonderful presentations and invaluable background information for our discussions over the next 2 days. We now have a break till 10:40 a.m. Eastern Time. Please join us then as we welcome a great new group of experts for our first session on improving data infrastructure to empower patients and providers.
Produced by the U.S. Department of Health and Human Services.